My name is Dylan Crail. I'm a student PTA at CBD College. My patient is a 43-year-old named Jamal who presents with an Achilles rupture. He is 2 weeks status post from his surgery, and his cast had just been replaced with an AFO, an ankle foot orthosis, and the doctor had just permitted him into partial weight bearing, as well as certain mobilization interventions. The AFO has been allowed to be taken off for range of motion activities. So due to these bullet points, I'd like to tackle a few interventions, exercises that meet the criteria of this phase of recovery, which would be acute. One aspect of recovery in this phase would be ambulation. So as we know, he is now partial weight bearing with his AFO. So we would like to start by putting him on either some crutches or a walker and begin a modified 3-point gait pattern that would start putting a little bit of pressure on his foot and allow him to go through the motions and begin increasing that sense of independence on his leg. As partial weight bearing goes, it's usually about 25% to 50% of your body weight placed on the foot. So we like to obviously start a little lower, 25, let pain kind of be the guide, and just progress further. Just take the walker, and as he moves the walker forward, he starts putting a little bit of pressure on his foot, not too much, and then he steps forward with his next foot. And we continue this aspect of ambulation until he begins growing more tolerance to the pain and to the pressure on his foot. Another exercise we would like to conduct to further the progression of recovery in this phase of acute recovery would be gentle stretching exercises of the foot. The doctor is allowing probably no sense of active plantar flexion unless otherwise specified, and absolutely no dorsiflexion at all. So what we would like to do is take the patient and maybe gently stretch the leg into plantar flexion, as well as inversion, eversion. Just as pain is tolerated, we want to begin to lengthen those muscles, especially the ones that aren't as affected by the surgery and not being lengthened as far as the surgical site being lengthened. So we would like to just do that as tolerated and within the parameters of range of motion that the physician is allowing as well. The goal of this intervention is to restore range of motion to a degree in plantar flexion, in eversion and inversion as well as maybe some gentle stretches to bring the foot slightly back into that neutral position, maybe not necessarily at 0 degrees, especially in the beginning, but definitely getting to that point. As by moderate phase of recovery, we're going to want to start bringing that gentle stretch into about 10 degrees of dorsiflexion. Last but not least, another exercise we can do within this phase of recovery would actually be isometrics within the foot. So as the ankle foot orthosis is on, we can actually have them do isometric contractions within it. As it's restricting the range of motion, his foot's going to be well contained within the assistive device. So if he can just contract those muscles, we can keep up circulation, prevent atrophy, and just keep that muscle to a degree strengthened through this phase of recovery until we can move on to the next one, and we can start adding a little bit more active range of motion once his foot's actually ready for that. But for now, we just want to keep those muscles from getting too atrophied, too relaxed, and just further into that phase of recovery. Within the acute phase, isometrics are allowed to a degree, especially if there's no sense of moving it into contraindicated locations. Parameters of the isometric exercise I would begin would be 6 seconds contracting, then 6 seconds to 10 seconds of relaxation, and then we would move back and do that maybe about 6 more sets just to begin, just to get his feet wet, no pun intended. And then we can move on to the rule of 10. I like the rule of 10 because it's easy. I think it would be easy for patients to remember. 10-second contractions, 10 seconds of relaxation, and we do this cycle 10 times. That's a good rule of thumb for isometrics within beginning phases of recovery. So we can follow that with Jamal as well. Precautions to keep in mind within this phase of recovery, as I might have touched on, is no dorsiflexion of any kind, passive and especially active, but we do not want to bring that foot past neutral right now. At best, we might want to get it to neutral towards the end of acute, but all in all, we want to keep it towards plantar flexion, moving into neutral. As when the recovery began, we had the foot fixed in plantar flexion, and now with the AFO, we are just trying to bring it back towards neutral, start regaining range of motion, prepare him for that mod phase of recovery. But until then, absolutely no dorsiflexion, no active range of motion into plantar flexion, unless specified by the physician, which we didn't get any guidance one way or another by that. So by default, no active plantar flexion. That's why I kept it to gentle stretches, just to start regaining ROM and just considering that as a ROM exercise. And last but not least, we want to remind Jamal, no matter how eager he is into the phase of recovery, no matter how much he might feel like he's ready to be weight bearing as tolerated, until we move to the next phase of recovery, we want to keep it partial weight bearing. We want to keep it in the beginning 25% weight bearing, up to at most about 50%. Once we get to mod phase, then we can start taking the training wheels off a little bit and bringing him into a little bit more into whatever pain tolerates. But until then, we must follow the parameters a little bit more strictly in this early phase of recovery. Additional interventions that I would recommend for Jamal during this phase of recovery, and even into potentially the next phases of recovery, is exercising the muscles that aren't affected. He wants to return to tennis, and by the time he returns to tennis, he's probably going to be a little out of shape. Definitely the cardio is going to need a little bit of work. And until he's able to start ambulating a little bit more normally, he's going to want to do as many exercises as possible that don't affect his lower leg. So upper body is fine. If he wants to hit the weights with his upper body, some trunk workouts, core workouts, all those are good as long as it doesn't involve involvement of the gastroc or the soleus or anything attached to that Achilles. So as long as he's not doing any squats that are pushing the foot past weight bearing parameters, we also want to just make sure that the lower leg is just not really involved. So we can do hip workouts. We can, as long as it's above the knee. So resistance above the knee is fine. Even if it's weighted, there's no restriction needed. So he can do hip flexor workouts, hip extensor workouts. Any of those would be fine. Also, patient education. We want to remind Jamal to do this ambulation, partial weight bearing, as much as possible, as normally as possible. We don't want to tweak the injury or over fatigue the muscle. So just trying to find that middle ground, but definitely learning how to become more mobile while placing a little bit more and more progressive weight onto the affected limb. Just keep the ball rolling and remind him that recovery is right around the corner, further recovery. Just reminding him that we can move into moderate phase in about 4 to 6 weeks from here, and we can start doing a little bit more weight bearing as tolerated, and then we can start doing a little bit more active plantar flexion, start moving that foot into dorsiflexion. The next phase is about 10 degrees into passive stretch into dorsiflexion, and as long as we keep everything on track, barring any setbacks, he will reach that phase within another few weeks, and we can get him returning to tennis in no time. All in all, we just want to keep him with a high morale as well as educated, and reminding him of the precautions, which I mentioned earlier in this video.